Hello, everyone. Thank you so much for coming to our discussion on the quadratus lumborum structure, function, and treatment. My name is Matt Callison. I'm here with Brian Lau, and we're here to shortly discuss this amazing muscle that we use quite a bit in acupuncture. It's also very popular in massage therapy as well as functional medicine. It's a muscle that has been discussed for decades as being a primary pain generator. But with the advancements within myofascial research and also with the biomechanics and functional medicine, the quadratus lumborum is actually evolving into a muscle that is different than from when I first learned about it in sports medicine in late 1986, early 1980s actually. So it has evolved quite a bit with its actual functionality. So Brian and I are here to be able to discuss a little bit about this muscle, give some quick assessment and some quick treatment techniques with us. And so, Brian, is there anything that you want to go for as an overview before we jump right into slide two?
No, I think we can jump on in, get the presentation up.
Yeah.
All right.
All right. So the quadratus lumborum is a complex muscle with various fiber directions. And this is what's so interesting about this muscle is that it's just not one pancake of a muscle that's going to elevate the ilium or lower the 12th rib, which is the way that I was actually taught in the early 1980s, late 1980s, is that it was an elevator of the ilium, which we really don't see that very much at all anymore. What we'll be discussing is looking at these different fiber arrangements and how this muscle is seen more of like a cross link between other muscles acting on the spine or the ilium. So it's really quite interesting that its role is more of a synergist or an assistant to a lot of other muscles in different movement patterns. So we're going to start to talk about that here in just a little bit. Let's look and see where it is actually oriented. You can see that the muscle is part of the posterior abdominal wall looking at this cross section of L4, and it's directly connected to the transverse abdominis. So Brian, can you get the cursor in there? And maybe, yeah, we can see that the quadratus lumborum has kind of a direct line along that core line right into the transverse abdominis. Now that's via the lateral raphe tissue. And because it's got such a strong connection to the transverse abdominis, that is the quadratus lumborum, if there are dysfunctions or increased tensions or lack of tension actually in the transverse abdominis in the anterior aspect, it will directly affect the quadratus lumborum in the posterior aspect, and also vice versa. Commonly you'll see this with certain postural distortions as well. Let's get into the lateral raphe just a little bit more here on the next slide. So let's look at the quadratus lumborum and how it's sandwiched between the anterior and middle layer of the thoracolumbar fascia. As we know, the thoracolumbar fascia has three different layers. It has an anterior layer, it has a middle layer, and it has a posterior layer.
Cursor, sorry.
Noticing you're actually doing a really darn job with that. I was impressed because that's not easy to do right now. All right, so we've got the quadratus lumborum and the three layers of thoracolumbar fascia. So increased tension, lack of tension of the quadratus lumborum, how it's going to affect the transverse abdominis, how it's also going to affect all layers of the thoracolumbar fascia. So that posterior layer of the thoracolumbar fascia is what we commonly see in the anatomy artwork or anatomy charts, where you can see on the backside the white tissue that's connecting the latissimus dorsi down to the glute maximus bilaterally. So that would be your posterior thoracolumbar fascia, and we just need to remember that there are two other layers, and the quadratus lumborum is sandwiched between those two layers. Very important. And let's see what's next, Brian. All right, so looking now from an anterior view, you can see that posterior abdominal wall, and you see the quadratus lumborum there, and also the psoas. So the psoas is something that Brian and I spoke about for, gosh, it was a 3-hour conversation on the structure, function, and treatment, which was great. It was a lot of fun because there were so many things to be able to discuss on the psoas, and that was in January. Or when was that, Brian? We did that.
Yeah, it was earlier in January, maybe mid-January. I think it's on Lhasa now recorded, but we had the live class still online live class in January 10th, it sounds like. I think seems about right.
Mm-hmm, mm-hmm. That was the first of the acupuncture anatomy series that Brian and I are intending to do quite a few videos within this umbrella or the folder of acupuncture anatomy. And this is the second one actually that's coming up soon. So what this presentation today is actually to be able to give you a couple of pearls that you can be able to really use with the quadratus lumborum and some knowledge about, some possibly new knowledge about it. And then if you wanted to actually go a little bit deeper with it, we're going to talk for about 2 hours or just over 2 hours on just the quadratus lumborum and its connections. Like I was saying before, the quadratus lumborum is seeing more of a crossroad now, like an assistant or a synergist to a lot of other functional movements. So it's a lot of fun. It's a lot of fun to be able to discover this and how it can actually be able to change needle technique and also treatment protocols or extra points that you can be able to use in addition to the quadratus lumborum. So not just local, but also adjacent and distal needling as well. So looking here at the anterior view, you can see the quadratus lumborum there that Brian has his cursor on, gracefully placed, I might add. And where the quadratus lumborum inserts, you can see it has a direct connection to the diaphragm there at the arcuate ligament. So that would be the lateral arcuate ligament. And then going over the psoas would be your medial arcuate ligament. So they actually, it's kind of like a sleeve where it is part of the function of the diaphragm, which is an important thing to remember when you are treating low back pain. So then also take a look inferior where that quadratus lumborum attaches to the iliac crest. It interdigitates, it becomes as one with the iliacus. And it's really quite fascinating to see on a cadaver because the fibers do actually come together. So if we were to tease away the fibers underneath the iliacus and the quadratus lumborum with a scalpel, just riding along the periosteum, you could lift that up and it would just become one tissue.
Yeah, and all the way to the diaphragm if you continued up that way.
Yeah, true. All right. So Brian, I think, are you taking it away now?
Yep, I believe so.
Okay.
All right, so this is from research with 6 cadaver specimens, really looking at the fascicle arrangement of the quadratus lumborum. Now keep in mind, this is 6 specimens, so it's not 100 or 200 or 300 specimens. But at least it gives starts to give an idea of the complex arrangement of the quadratus lumborum. And when looking at these specimens in this research, there's 3 layers to the quadratus lumborum. We're looking at the back through the posterior part of the body right now. So we're looking at the posterior layer, but then there'd be a middle layer and there'd be an anterior layer. So there's really 3 layers to this complex muscle of the quadratus lumborum. And this particular research then compared these 6 specimens and looked at the various fascicle arrangement. And this is something we might expand upon when we do the longer 2-hour class. But just to give a quick overview of this now, first of all, there's a lot of variability from specimen to specimen, variability in size, placement, really number of fascicles, all those types of things. But generally, there was mostly at least half of the fascicles acted on the 12th rib. And there were iliocostal fascicles. So that's what you see outlined in green from ilium to the 12th rib. There was iliolumbar fascicles. That's what you see in that more yellow line from the ilium to the lumbar spine. Actually, there were some iliothoracic fascicles that went all the way up to the body of the 12th thoracic vertebra. But by and large, these are the bulk of the fascicles, is these iliocostal and iliolumbar. The middle layer is the one that has the lumbocostal from the transverse processes to the 12th rib. You can't see those from this image, but that would be kind of sandwiched in that middle layer. So do you have to memorize all these different fascicle arrangements? Not necessarily, but to understand the role, or at least to understand the complexity of this muscle, it's important to remember that there are these various layers, some going from ilium to rib, some going from ilium to lumbar spine, some going from lumbar spine to the 12th rib. So very complex in its fascicle arrangement and size and everything. So because of this complexity, the muscle fiber and fascicle orientation of the QL, it's difficult really to identify the actions when you're looking at the quadratus lumborum and its line of pulls. It'd be one thing if it went from ilium to 12th rib. If it was just like a straight shot from the ilium to the 12th rib, you could speculate much more easily of what this role would be, because it would be acting from the hip to the rib, and it would be a little more of a straight shot. But because of the fact that there's these various forces, various vectors acting on it, there's a lot of uncertainty on the role, the action of the quadratus lumborum. So let's go over the general actions. Notice that all of these, at least the first two bullet points on the actions, have an asterisk. So let's kind of talk about the asterisk first. So these actions are really placed under question right now by researchers because of just what we said, because of this complex arrangement. So it seems that maybe the quadratus lumborum has not so much to do with a particular action, like let's say lateral flexion of the trunk. The obliques are in a much better mechanical advantage to do lateral flexion of the trunk, but the quadratus lumborum is there to help out with it, to assist with that, to sort of be a helping aid. At the same time, it can stabilize the spine. So there's a lot of stabilization roles of it, probably and potentially, and that's what the research seems to show. Extension, some sources say extension. Well, it doesn't really have a good leverage to do extension, but it has leverage to help with extension, help with the erector spinae. You can see a lot of different rotational aspects based on the fiber direction. So really what it seems like is that, like what Matt mentioned, is really more of this cross-link. Where it's helping and assisting more functional units of structures that are moving together. But the traditional roles of the quadratus lumborum is that there's a unilateral contraction, or when there's a unilateral contraction, that does lateral flexion of the vertebral column of the lumbar spine, and whereas the opposite side then would be stabilizing. So if we were looking at this right QL, it could laterally flex the lumbar spine. So it'd be the lumbar spine would become concave to that side. Bilateral contraction is where it's usually talked about as extension, but it seems like it's pretty minimal in extension, more about assisting if it does it at all. And then it does seem to have a role in assisting with inspiration because of its pull on the 12th rib. As the diaphragm contracts, it would want to lift the 12th rib. So the QL is under there to kind of stabilize the 12th rib and aid in kind of countering the diaphragm's pull. So this would be important with things like speech, singing, anything where you're getting up there and really projecting your voice in particular. You could kind of picture that QL being there to sort of assist with that. Mm-hmm. So complex muscle.
Mm-hmm. Yeah. So those, hey, Brian, can I add something to that?
Sure, absolutely.
So the first two bullets you guys with those asterisks are that research. They actually did some EMG studies on that, and they had the patients the models go into extension of the lumbar spine as well as lateral flexion into a number of into the muscles that actually act on the spine. And what they found was that the erector spinae was actually like 90% involved in the extension of the lumbar spine, whereas the quadratus lumborum only 10%, which really is very interesting. And they basically had the same results with the unilateral contraction of the quadratus lumborum as well. How it wasn't really actually a primary mover. It's just, again, it's like more of a cross-link, a crossroad, a synergist, an assistant, a stabilizer. So it's really quite fascinating with that. And I think
we were discussing this recently, Matt and myself, and I feel like working on the muscle, which is kind of jumping ahead, and I don't want to get into too much on that now, but if the lumbar spine is in hyperextension, to me, I never really think that I really want to lengthen the QL so much, because it seems like it has a minimal role in extension. But to be able to get that free gliding of the QL and the erector spinae, and to be able to sort of decompress the tissue. So you can kind of almost try to lift the tissue out from being sort of buried deep into the lumbar spine. To me, that's how I think about it more, and its role of extension is more postural and less dynamic, so to speak.
Yeah, the QL being more of a postural muscle. Like, for example, in single leg weight bearing, in order to have the stability of the lumbar spine, then the lateral sling comes into play. So you've got the glute medius and the minimus and the tensor fascia lata on one side, and then you've got the quadratus lumborum on the opposite side, with that sling being able to keep the balance in the frontal plane when somebody is standing on one leg, and how important that actually is. This is something that we're going to discuss quite a bit further in the longer discussion of the quadratus lumborum that's coming up in a couple of months. It's important, gives you a lot of great treatment protocols and ideas about what sinew channels to be able to treat locally, adjacent, and distal, as well as myofascial work. And in addition, exercises to prescribe as well. That's going to be very important with that frontal plane.
Mm-hmm.
Cool. Right. Boy, we talked about that slide for a long time.
Yeah. So right, the quadratus, I'm sorry.
Yeah, you're on still.
Yeah. The quadratus lumborum has a relationship in terms of at least the topography of it with the lumbar plexus, but it's really a little bit more complex than just that. So first of all, just a review of the lumbar plexus. This is coming from the ventral rami of L1 through L4. But if you look at this top image, the subcostal nerve, the T12 intercostal nerve, which is called the subcostal nerve, shares some fibers down into L1. So really the subcostal nerve contributes to the lumbar plexus. Why are we focusing on the lumbar plexus? Especially this upper portion, the subcostal nerve, the iliohypogastric nerve, which I don't know if I can see this on the screen, but subcostal nerve would be right under that 12th rib. Then the next one to come out would be the iliohypogastric, and then the ilioinguinal nerve. Those travel right on that anterior surface of the quadratus lumborum. Okay, interesting. But those are also the primary innervation sources, which especially the subcostal nerve, which is Matt is going to get into in just a moment. But something to kind of bear in mind as we get a little farther in the lecture, we'll come back to this and talk about it, is if we follow these nerves that wrap around the posterior part of the abdominal wall and start to become anterior, is they have cutaneous sensory branches that create sensation, that supply the skin and the sensory aspect for the posterolateral gluteal region. I think that says thigh, but that should really say the gluteal region, posterolateral gluteal region, the greater trochanter region, the suprapubic region, and the proximal medial thigh and groin. So hold that thought. We'll remind you about it, but just keep that in mind that the nerves that are kind of part of the innervation of the quadratus lumborum, that have a structural relationship in terms of where they are, have those sensory distributions to the lateral hip, greater trochanter, groin, and kind of up in the suprapubic region. So we'll come back and look at that and how that applies in just a bit. Anything you wanted to add to this, Matt, before jumping into the innervation and motor point?
It was a good setup for what's to come.
Yeah. Pique some interest on it, right?
All right, so we're staying within the motor nerve innervation. So this is some research that I gathered. It's really quite interesting. I found this to be true, is that varying research articles and textbooks, there's not agreement on which nerves actually innervate the quadratus lumborum. But the most important one will end up being the subcostal, mainly with the research that's below, because of its large diameter. Its measurement of being so large diameter. Therefore, you're going to have more sensory and motor neurons within that motor nerve that's going to be entering the quadratus lumborum. And then it also discussed the ilioinguinal, iliohypogastric nerves that were also innervating the quadratus lumborum, but with those nerves actually having less contribution to it. So there are, what we know of is 3 primary motor entry points, with the biggest one, or the go-to one in my mind, will be the one that the subcostal nerve is actually going to be innervating. So let's go to the next slide, because it does show some research on here, and you can see. So here, you've got the T11 intercostal nerve, and then you've got the subcostal nerve will be B. You can see that it's has a larger spread and innervations to that. Now, what they did is actually they opened up that subcostal nerve so that you can actually start to be able to see the different branches. Then C is going to be your L1 anterior rami, and D would be your L2. So C would end up being, I believe, part of the ilioinguinal and possibly part of the iliohypogastric. So you can see how that subcostal nerve in B is going pretty close to. Brian, can you show On the far upper left corner, that the iliac crest, the ilium there. Yeah, there you go. So you can see how that subcostal nerve is going toward the muscle belly of the quadratus lumborum. So we'll discuss the subcostal innervation coming up in the treatment section. All right, Brian.
All right, so some of the work we teach quite a bit and work with in the sports medicine acupuncture program is the sinew channels. So we've really been working for probably 10 years now, coming up on 10 years now, on really building a comprehensive model for the channel sinews, Jing-Jin, sinew channels, whatever translation you're using for those. And really highlighting the specific anatomical structures that are associated with each channel sinew, how they relate functionally to seeing things like their external internal relationships, in this case, the gallbladder sinew channel, or other correspondences, so how they function together. But for today, just looking straight at the myofascial plane that makes up the liver sinew channel is quite interesting, because this one is a little diverges a little bit from the classical description. The classical description has the liver sinew channel terminating or ending at the groin, at the genitals, I think specifically is what it says. But if you look at the myofascial plane, it has a much more interesting relationship in that line that's coming up from the foot through the medial thigh up through the adductors, adductor longus, brevis, pectineus, gracilis. Adductor magnus is a different one that's more in the kidney sinew channel, but this more anterior line of the adductors, longus, brevis, and pectineus, that would be then very continuous with that fascial plane all the way up into the iliacus. And as Matt mentioned, where the iliacus shares fascial fibers, kind of interdigitates in with the quadratus lumborum. So, and then up into the 12th rib. That would be the liver sinew channel. So if you follow that plane deep into the pelvic structure of the iliacus, it would come out into the QL. And I know a lot of people might be thinking, well, QL, it's a back muscle. It seems like that would be urinary bladder maybe, or maybe even gallbladder sinew channel. But if you think about it as being less of a back muscle, which it really isn't, but more of an abdominal muscle, it's in the abdominal wall. It's much more of a yin muscle, much more of a core sort of stabilizing deep structure. It starts to make more sense, especially then when you look at that continuous fascial plane through the adductor line up into the iliacus, QL, and diaphragm. The iliopsoas would be part of that also, especially the distal fibers of the iliopsoas. It's a little more complex than we can get into today, but we covered this quite a bit in our psoas 3-hour class and the different sort of relationships with the psoas. But that distal portion in particular would be part of the liver sinew channel also.
Mm-hmm. Yeah, Brian, what sold me on this one was that, Jay, when you gave me a call and you said, hey, try this liver 5 points. And my practice on every person that day, I palpated their quadratus lumborum and then needled liver 5. And it was remarkable how well liver 5, the low point of the liver channel, softened the quadratus lumborum on not just a couple, but every single one. And in particular, we've been teaching this for Yao-Yan syndrome, or the deep layer, which we're going to actually be talking about here just a little bit, how to feel that Yao-Yan syndrome. But it was pretty magnificent to be able to feel how liver 5 and in combination of liver 3, and I think I might be jumping ahead with information.
Yeah, that's fine.
Yeah, it is. It's kind of remarkable how well that does work. So I think we're going into assessment now.
Yep, that is the case. So,
all right, so want to go?
Oh, go ahead. No, go ahead.
Okay, so with the elevated ilium, this is one thing that we can be able to look for, that we know that the quadratus lumborum, the myofilaments, the actin and the myosin, are going to be in a locked short position. And it's not because it's pulling on the ilium, pulling upward, but it's because the glute medius and the minimus have weakened and are allowing that ilium to actually rise up. The opposite side, glute medius and minimus, are then shortened and pulling that side down, the opposite side down. So it's the opportunity for this muscle then to become shortened. Now, commonly what we'll see with this as well is a lateral tilt of the rib cage on the same side, which you want to go to the next slide. All right, so when you get that elevated ilium, what the body wants to do is to compensate, start to lean to the same side so it can start to balance itself. So that would be another sign that we can observe when looking from the posterior view. An elevated ilium, always go ahead and measure it with your fingers as well, just to confirm your visual findings. And then look at the lateral tilt of the rib cage. Usually with the love handle, so to speak, you'll see a difference between right and left sides, and more of an accumulation of tissue when there's an elevated ilium and a lateral tilt of the rib cage. So in that case, you've got the T12, this 12th rib is now going to be actually coming down, and which means shortening of pretty much all of the fibers of the quadratus lumborum, I would think, making pigund tender to palpation, and also Yaoyan tender to palpation, as well as the motor entry point. Let's go to the next slide. Brian, you want to chime in on this at all?
Quickly on this? Yeah, in this particular image, so it looks like really more just lateral tilt without so much of a elevated ilium. A little tricky to tell, right? We'd have to kind of almost get in there and get our fingers on and make sure that what we're seeing on the exterior surface matches. But just glancing at it, I don't see a whole lot of elevation of the ilium this particular person, but more about the lateral tilt, more about that 12th rib kind of being pulled down. So you don't always have to see an elevated ilium with it, but frequently you'll see these two go together, elevated ilium and lateral tilt of the rib cage. This particular person was a massage therapist, so she leans a lot with her right arm, you know, in terms of like using pressure with her right arm quite a bit. So you can kind of see how that would have a propensity to shorten that right side. Oh, do you want to say before we move on, Matt, that these distal point recommendations are just go-tos that are frequently helpful for this condition? There's ways we apply these in our program and really make determinations of which points to use, but you can just try them out and experiment with them in terms of the part of the full comprehensive treatment, in addition to the local points, which we're going to be getting into. This is just a portion of the treatment, right? This isn't like a whole treatment is treat the QL, out the door you go, and the person's better. It might temporarily help, but you need to be much more comprehensive to get lasting results. And looking again at the fact that the QL is a cross-link, so we need to treat multiple structures and look at its role in communicating between multiple structures instead of just QL, maybe put a little electrical stim on it, out the door, next patient comes in.
Mm-hmm. Yeah, I forgot because we grabbed these slides from the Sinew channel class, which we have recordings for. So the acupuncture distal, those points we're using as acupuncture as an assessment. We've discussed this a few times before. Basically trying to be able to change an orthopedic exam and manual muscle test a certain particular posture by using different acupuncture points that will change that myofascial sinew channel before and after. And using acupuncture and assessment, it's just basically seeing, can you make a change in that body using these acupuncture points? And once you can see it and retest it, then you pull those needles out, but you remember to be able to plug those needles back in during the comprehensive treatment of acupuncture, because you saw how it actually makes that difference. I think that's where this is coming from. Good. I'm glad you explained that, Brian.
Yeah, maybe this is not a great time. I think there was some question on the QL and the diaphragm. I see some references to it, but I don't see the actual question. So we'll catch that at the end if that hasn't been answered already. There it is. Would needling the QL motor point help and effect with the diaphragm? Yeah, I would say that I use the QL personally, and I'll see what Matt has to say about this. But personally, when I'm working with respiratory issues, I don't even want to say respiratory issues because that's a broader category. Restricted breathing. When the breathing seems like it's a component of the back pain, maybe the person is more of a chest breather, and that deep diaphragmatic breath isn't sort of filling the low back and massaging the spinal joints and kind of expanding. And, that elastic aspect of the inhale, exhale, expanding the lumbar spine and expanding the soft tissue structures in that lower part, I definitely go to QL as part of the treatment.
Absolutely. Also the psoas, because we teach a way to be able to see if the low back pain is actually could be coming from a weakening or an inhibited psoas that's been constricted in the diaphragm, there's a manual muscle test that you can use with that. So yeah, for sure. So add also GB27, UB17, UB23 for the kidneys, psoas, and also quadratus lumborum, I think would be a good idea.
I'll say one other thing about it, then maybe move on unless you have anything else to add, Matt, to it is I also think about what's at the other side of the rib cage. So you have the QL attaching to the 12th rib, and then you have the scalenes attaching to the first two ribs. And I find that especially with people who are more of these chest breathers who are overusing the scalenes, is that relationship can be very important. As speaking to scalene, especially the anterior scalene, is a little hard to needle unless you've had specific training on it. But at least some myofascial work or some softening manual work to help free some of that excess tension in the scalenes. And then speaking to the tension at the QL, you're kind of working on both sides of the rib cage. That can be really useful. All right.
This is great. How far should we go on this? We'll start talking about forward head posture and
yeah, for sure.
You know, we got to get going. We'll never get. All right. So yes, let's now talk about needling these points. So in the upper left image, you can see palpation of the extra point P gun. So we know that P gun's going to be located 3.5 some lateral from the lower border of the spinous process of L1. Really what I'm going for in this particular case is the corner pocket, I call it. It's where the iliocostalis, also the quadratus lumborum, where they attach to that 12th rib, and you're just palpating along the 12th rib from the lateral aspect up into that corner. You can see a bit of a crease there. So the needle then would be inserted the same direction as my middle finger, and making sure that it's not going to go anterior to the 12th rib. So it's a really good idea to palpate that 12th rib and the topography of that 12th rib, because you don't want it to go anterior. That could cause a pneumothorax. All right, so you don't want to insert that and go anterior to the 12th rib. Caution is advised. Then you can look at the motor point, which is going to be approximately halfway between P-gun and Yaoyan. It's not on everybody. The directions for finding this motor point is going to be just lateral to UB52. On some people, you can find that just slightly more superior from the midpoint being between extra point P-gun and Yaoyan. So that's one aspect that you can get it, or you go slightly higher. If you can find UB52, that's going to put you in the ballpark of that subcostal innervation. So insert the needle, make sure it's going to end up being parallel to the table. With the quadratus lumborum, I'm sure all of us have gone ahead and needled that quite a bit. Being an educator and seeing a lot of people that are needling the quadratus lumborum, palpation is everything here. And you need to be able to make sure you are actually on that QL and on the deeper layer. I see a lot of students actually needling the iliocostalis, which is going to get results, absolutely. But it's not needling the quadratus lumborum, so it's going to be different intent there. Then we have in the upper right-hand corner, we have Yaoyan. This is going to be the deep layer of Yaoyan, which would be the quadratus lumborum attachment on that lateral aspect of the pelvis. And it's amazing how far the quadratus lumborum actually attaches to the pelvis. So this particular needle technique is not going to be on the edge of it, but it is going to be going through the quadratus lumborum in a cross-fibered direction. So you're influencing quite a bit of the proprioceptors there, the Golgi tendon organs and such. Brian, anything to add, or you want to jump to the next one?
No, let's go ahead, and I think the next one just shows some images of the
needling
placement. Mm-hmm.
Mm-hmm. All right. So we just described that pretty well. I think you guys can be able to see that in the image. These images are from the Sports Medicine Acupuncture textbook. And now...
Yeah, so we've already kind of discussed liver 5. So when I was talking about the lumbar plexus and those nerves that wrap around, some of which innervates the QL, the subcostal, iliohypogastric, ilioinguinal. Matt, do you know if it's the? I always hear that it's the L1 and L2 anterior division, the anterior rami for QL, or at least I've seen you indicate that. Is that branches off the iliohypogastric and ilioinguinal? Because I know those are L1 and L2 region. Or are they like before the lumbar plexus branches off?
I didn't understand your question because it is the iliohypogastric and ilioinguinal, and I do agree that it's the ventral rami. That's how it's talked about. But what was your question?
My question is, sometimes I've just seen reference to L1 and L2, and I wasn't sure if it was before, if it was the ventral rami or rami before they get to the lumbar plexus. There's like a motor nerve that branches off before intermingling with the lumbar plexus, or is it post lumbar plexus? If it's the ilioinguinal and iliohypogastric, then it's definitely post lumbar plexus.
I don't know. It's going to be one more thing for us to be able to go research.
Yeah. Anyways, those have an intimate relationship with the QL. And it is kind of intriguing that the pain referral, the trigger point referrals, many folks here probably have worked with trigger points or maybe use them as part of the assessment. I use them. That's not the only thing that can refer and cause pain, but I think it's a useful thing to look for, especially QL is so frequently involved with a lot of low back pain patterns. And when you look at the QL referral pattern, it pretty much goes to where those sensory divisions of the nerves go to, to the lateral, posterior lateral gluteal region, to the greater trochanter region, wrapping around to the suprapubic region, and then wrapping around to the groin. There's also some divisions that go really more posterior, deep into the gluteal kind of SI joint or into the kind of deep buttock region. But to me, that's doesn't really talk about it this way in literature when you talk about trigger points. But to me, that sort of emphasizes that segment has become irritated. The QL, maybe the QL is the irritating factor, maybe the QL is part of the irritation of that segment, but the sensory division of that complex, so to speak, has been irritated. Maybe. That's open to debate, and I haven't seen it quite summed up that way in discussion of trigger point sensitization. But it would make sense to me because there's such a neurologically intimate relationship between those nerves and the quadratus lumborum. But to me, that also speaks to the possibility, or at least a possible mechanism of how liver 5 is so effective for the QL, is that maybe it's working with that collateral circulation, being the low connecting point. It's working with that collateral circulation that is referring pain both to the gallbladder channel distribution and the liver channel distribution. It kind of has a referral that's between these two internally, externally related channels. And it's interesting that it's the low connecting point that would have such a strong relationship in terms of removing pain from the quadratus lumborum and helping sort of with that pain referral sensitization. And then this is something that I've been working with, and Matt started adding liver 3, and that seems to really increase the effectiveness. I mean, liver 5 by itself is quite effective, but liver 3 and source and low point on that channel is just even a stronger treatment. So this is a really great distal point combination that you can use in combination with the local needling that we just covered for that side where the QL is really a pain generator. Yao-Yan syndrome or something like that in particular.
It's interesting to see the image, the trigger point image that's on top there on the upper right. You can see where the X's are right at Yao-Yan and Pigun in that region. So, I mean, these points have been needled for thousands of years or have been known to be a referring type of point, a trigger point. Yeah. And then the points lower, let's see the deep ones. Is that around UB23 region? Is that upper one? Because the other one looks like it's kind of close to multifidi almost. Or
yeah, so this is what, well, first of all, let me give a quick statement that this is the old edition of Travell's book, because I think I think it's the 3rd edition, the newest edition. They've taken out these X's because trigger points can form anywhere in the muscle. I kind of like the X's. I mean, it's pretty accurate.
Around for a long time.
Yeah, I mean, Travell's passed on now, so the decision was kind of made after the fact. Now I guess they're basing it on ongoing research and such, but they made the decision on the 3rd one, which is, I understand the decision to take out the X's. So I think the X's aren't saying that this is where the trigger point is going to be in this referral, but it's just tendencies. There's a tendency for that upper, especially more lateral fibers to have this, that's marked 1, to have this referral, which I find is pretty commonly the case when it refers pain, that's where that trigger point sort of lives. And more of that lateral edge of Yao-Yan tends to have more of that number 2 distribution. Then if you go deeper, if you advance the needle deeper, and to your question, Matt, I kind of wonder the same thing. Are you actually hitting those medial fibers of the QL, or are you starting to get into attachments of the multifidi? Because they blend so much together. We've seen that a lot on cadaver specimens, but those are the ones that tend to refer deeper down. And I kind of wonder that same aspect of this is QL, or if it's the relationship of the QL to the deep multifidi, which are on the same layer. And I kind of think that.
It'd be really interesting the next time that we get an opportunity to dissect this, Brian, is to follow the subcostal nerve into the motor entry point. And then if we have time to do this, would be great, is to see if we can then do intramuscular dissection and just follow where it starts to bifurcate. Is that smaller branch traveling intramuscular going to Yaoyan and Pigo? And it'd be fascinating to see if we could actually follow it up there. Guy, you and I we're really geeky.
That's why, by the way, that's why I like the X's, because I think that's what the X is. That tendency is probably more intramuscular sort of innervation sites.
Dr. Travell is probably rolling in her grave, because if they're going to take those X's, I don't know.
Could be. All right. Well, interesting channel discussion, but it's a really effective treatment. Palpate QL. Give it a try yourself. Before you actually needle QL, especially Yaoyan seems to be really highly effective this way, is palpate to get a pain scale from your patient. Let's say, oh, that's a 7 when you really get on that. That really gets to the source of pain. Needle liver 5, liver 3, and then go back and palpate it and see what happens. And I think you'll find that if you get a really good Chi response at those distal points, that in and of itself reduces pain by 50% or more. And then the rest, you getting with the local needling is a really big part of the full treatment.
That's good.
All right. We teach a lot of myofascial release techniques in the program, especially like targeted ones that will really supplement the treatment. And this is a myofascial release technique for the quadratus lumborum, especially getting to that lateral edge. If you try to reach the QL through the erector spinae, good luck. That's a really thick layer, especially in the lumbar region of tissue. So it's, maybe you can touch it, but you're going to have minimal influence on it with your fingers. You get a needle in there, but it's hard to determine the depth, because you don't know exactly where you are when you're just going perpendicular. That's why the needle technique Matt showed was going more from lateral to medial, almost the same way my finger is there, but he was showing it with the person in a prone position. So this will be very much like the needle technique, as we'll come anterior to the iliocostalis lumborum, pretty much at Yaoyan, hugged up right against the iliac crest. You can angle your finger once you get a really deep contact there and kind of engage the tissue. You can angle that pressure up towards the 12th rib and have the person reach their leg down to bring the hip down. So their thigh, you can't see it fully in this image, but their thigh is in line with their torso. So as they reach their foot, say towards the back wall or something, straight in line with the torso, downward, that'll start to pull the hip down while you're spreading and moving that tissue towards the 12th rib. So you're elongating one direction as their force is going the other direction. And you can take that up to the 12th rib, then you could change directions because of those different fiber orientations. You can change the orientation then down towards the iliac crest and have them reach their arm upward to pull the rib cage up, so you're decompressing the tissue away from the 12th rib, and then bring the tissue down towards the ilium as they're having a force in the opposite direction. Really effective technique after needling, and it can help return that tissue to a really good resting length.
Mm-hmm. Yeah, there's a lot of
really
good techniques in that class. Yeah, that's good. A lot of good ones to use. Same thing with myofascial techniques, and same thing with needle techniques, is there's a lot of good exercise techniques as well, trying to be able to accomplish and reinforce your treatment. Thinking about it still as excess and deficiency. So when you have a locked short muscle, it will act like it's excess, but it will be an underlying deficiency. When you have a locked long muscle, it acts as a deficiency. So it's a good idea to, once you reestablish the channels and the chi in blood and the axoplasmic flow that we discuss in the actual muscles and the channels themselves, it's a great idea to go ahead and strengthen the locked long muscles and then try to be able to stretch those locked short muscles. This is one particular stretch. It's one of our favorites. It's one that's a patient favorite as well, the figure 4 spinal rotation, where you have the ability to elongate the quadratus lumborum, you can see on the lower photo that she has crossed over that figure 4 position. So her right foot is on the floor, and the lateral aspect of her leg and also thigh is going to be on the floor as well. So for her to be able to bring her right knee into hip abduction, that helps to lock down and pull down that ilium that could be elevated and causing a shortening of the quadratus lumborum. So great exercise to be able to use. Like I said, it's a patient favorite. It helps to release the quadratus lumborum as well as to activate that glute medius, which is going to end up being part of that lateral sling that we briefly talked about, and we'll talk about it quite a bit more in our 2-hour lecture coming up in just a couple of months on the quadratus lumborum. So, Brian, I think that's it, man. We went way over time. I hope that's okay. We have references as well, you guys. We also have something in the notes that you guys can go ahead and take a look. Mm-hmm. We have a number of different recordings. About 75% of our SMAC program is now recorded and also on LASA OMS, which is great. Also, the SOAS class, the 3-hour class that Brian and I did just this last January, that's available as well as part of the Acupuncture Anatomy series. LASA OMS also carries the Sports Medicine Acupuncture textbook, which is the next slide. And so I think we're probably good to go. Brian, anything else that you want to be able to say?
Yeah, one quick, the SOAS class is great on LASA, and it's much more comprehensive because we have more time. But there was, we did do AAC, SOAS, if you want to get a little taste for that class. That was in, I remember, November. So if you go on AAC's page, you can search back for the SOAS webinar we did there also. So that's give you a sort of a sample of that class, and you can see it through AAC's page, which we always appreciate them having us on and
big, huge thank you to American Acupuncture Council. Yeah, absolutely. Big, huge thank you for having us and supporting us. Thank you so much with that. Brian, that was a good call to be able to bring that back in. SOAS. That's good. Anything else, Brian? Lauren Brown. Yes, he's going to be here next week. Make sure you check him out. He's a big professional in our field, a wonderful academic, and an amazing practitioner. So check him out. He always has really interesting things to be able to say. Thank you very much, American Acupuncture Council. Mm-hmm. Brian, always nice hanging out with you. I'll talk to you again soon, buddy.
You too. All right.
Okay, bye, everybody. Bye.